Welcome to this MedStro Google Hangout that we've titled Physician Technologists Take on the Triple Aim. I'm Joe Elia for the NEJM group. We're having this discussion at the start of the group's online open forum, which ends on January 21st. Two of the experts who will be participating in the forum kindly agreed to talk on camera. We have Dr. Yiding Yu of Triage and Dr. John Moore of Twine Health. Thanks for giving us some time today. I wanted to start off with a nod to the founders of the Triple Aim. Donald Berwick and his co-authors published a manifesto in the May-June 2008 issue of Health Affairs. They defined the target this way, quote, improving the individual experience of care, improving the health of populations, and reducing the per capita costs of care for populations. It's a brief article worth looking for if you haven't had the pleasure of reading it already. I want to give you both, Dr. Yu and Dr. Moore, a chance to ask questions of each other, but to start off, let me ask each of you. Do you think that the profession as a whole gets the Triple Aim, or are there still conversions to be made out there in the clinics? Dr. Yu?
It's a great question. You know, I think that I work and practice every day at Atrius Health, which is one of the largest outpatient providers, and it's really is focused on a primary care foundation. I think primary care, and among some of the other specialties, I would also name behavioral health as another one. There's some specialties that have very much embraced population health, viewing that doctors as a profession have responsibility to care for many patients, not just a single patient, and that the cost of the entire system matters to everyone, not just to insurers, not just to providers, but to each and every individual patient. So coming from the primary care side, I think very much so, we're on board. But when I talk to physicians about individual areas where we get into policies that promote the Triple Aim, where there might be tensions that providers see with patients. For example, when we rolled out changes a few years ago about prostate antigen screening and encouraging that they should not be pre-lab standards for all of our patients anymore, or for our gentlemen. And I think when we explained the medicine behind it, at first there was some pushback, some controversy. Over the years, as the data has collected, more and more physicians are on board. But even still, there's some uncomfortable conversations that they have with their patients, where patients say, well, if I'm comfortable with the risks of overdiagnosis and overtesting, why can't I get this test? If it's a cost thing, I'm happy to pay for out of pocket. I just had another patient the other day ask me about strep throat testing. He didn't have any sore throat, and so I said, I don't think you need a rapid strep test. But he was concerned. He had been exposed to someone, and he said, if it's because of cost, I'm happy to pay for that test. So I'm already feeling how our patients feel that there might be a rationing of their care, and I think from a doctor's perspective, that feels really awful sometimes. I never want my patients to think that the reason why I'm saying we shouldn't test for strep throat is because I'm trying to manage costs so much, or I'm trying to think about populations and not the person in front of me. So I think there's going to be some natural tensions, and when patients and providers have to think about the patient-doctor relationship and that very individual relationship compared to that whole population, there are still some points where it might be uncomfortable, but we're getting better and better at having those conversations.
And Dr. Moore, what about you? In your experience, do providers or clinicians get the Triple Aim, or actually, if you asked them, would any of them be able to recite the 3 points?
Yeah, I think to your first question, yes, they get it. I think that there's a general consensus that we need to improve outcomes, decrease the cost, and improve the experience. I think the major problem is that for most of them, the business model of healthcare gets in the way of that. And that is when they start to waver. Is they say, yes, I believe in better outcomes, but I work in a system that tells me I need to spend this much time with each patient and document these things in order to generate that bill, and that's very inconsistent with the goals of the Triple Aim. So I think, yes, there is a general consensus. I think For the most part, clinicians out there really want to achieve that, but they feel a tension that it is the world of the way healthcare gets paid for is against that. And we work with a lot of organizations that are on the other side of that, where they do get paid differently, and they feel liberated and feel quite gratified in really focusing on the AAA. And I think everybody will be getting there now that healthcare reform is really starting to change the payment paradigms.
But there was an interesting article over the weekend in the New York Times business section about the doctors in Oregon who have decided, they're hospitalists, who've decided to unionize because their hospital has decided to outsource the hospitalist role. And they relate that, I don't know whether either of you has had time to read the article, but the hospital said, the internist went to the hospitalist rather went to the hospital administration and said, you know, we're unhappy about this, and they said that the hospital said, listen, the whole point of this is revenue, and the hospitalists realized, oh, they weren't on the same page at all. The hospitalists are trying to improve care. So they said, and the hospital administration was offering what they called the skin in the game approach to using hospitalists. But that aside, Dr. Yu, could you please give me this is the elevator summary section of the opening. Could you please give us a summary of what your company is trying to do to achieve the triple aim, or what your company is doing?
Absolutely. So I wear two hats. My first hat, I think, that I think you're alluding to, is my role at Triage. So I'm the founder and chief medical officer of Triage, which has developed an interoperable cloud-based platform that allows ambulances to directly communicate with hospitals. What we basically do is replace radio and cell phone communications that happens today when any ambulance needs to transport a patient, whether from a nursing home or due to a 911 call to the hospital. The only way they can have a conversation with the hospital to alert that they're coming is over a radio. And that's a one-time analog communication that isn't saved or easily accessible by doctors later on. And it also means that there's no ability for the hospital to know the name of the person. You know, they can't know that's getting you. They just have a Jane Doe coming in. There's no way to compare my EKG with an old EKG or look up my medical record. So it helps, it's actually the existing state perseverates the problem of retesting and ordering new and costly exams, which they aren't needed, but also delays care. So if you do have a patient having a critical stroke, you don't want to wait until they actually arrive in the ED to be able to do a physical assessment. What Triage allows is the ability to send photos, videos, audio, and discrete data points like vital signs and interventions. So as the patient is being treated at home or in the field, the hospital is already preparing for their care. And we address the triple aim in a few ways. One, oftentimes when hospitals look to ambulance patients, they're just seeing them at one time being called over by a radio. So there's no understanding of the whole situation of the traffic coming to the ED. Hospitals oftentimes have a great deal of burden when managing their busy emergency rooms, and they want to be able to provide the right care for the right patient at the right time. And most emergency departments, you know, this is not an area that traditionally thinks about population medicine. They think about, what am I going to do to save that patient's life? But more and more of what they do is has a role in population health. 80% of patients who are transported by ambulances to the hospital are actually routine cases, meaning that it's not that they don't have a need to be seen in the hospital, but they probably don't need to be admitted, or they weren't unstable in any way and can be more managed in a long-term process. So hospitals are using Triage, are getting better situational awareness about the patients that are coming in. They now know which patients truly require tertiary medical care and accelerated care, and that helps improve those patients' outcomes for heart attacks, strokes, and traumas. And for the other patients who are more chronically ill and have a smaller acute issue, they can have a better ability to look at their medical record, look at their medication list that triage is sending them over, compare that, have a chance to reach out to the PCP and understand what the emergency department's role is in managing that patient and hopefully preventing a readmission or preventing a new admission. So those are the roles that triage is helping with hospitals.
Dr. Moore, what about you? Your company is providing, I believe, healthcare coaches. Is that right?
We don't provide the coaches themselves. We provide a software platform for improving the efficiency and effectiveness of health coaching. So there are estimates now that in the next 5 years that health coaches will be the largest growing segment of the healthcare workforce. Health coaches and other extenders of physicians and nurses. And their role is really to work with patients between visits to help them achieve health outcomes and to overcome barriers in their care. And our platform connects them in real time with patients through what we call action plans that help them set goals, track adherence, measure progress, and also with video and text-based secure communications. And our customers currently have some of the largest impact hypertension and diabetes outcomes in the world. For example, we have a study that just was published with the Joslin Diabetes Center showing a 3.2 drop in hemoglobin A1C in 3 months. The norm is a 1-point drop in a year for patients starting insulin. And with the Massachusetts General Hospital, we have a randomized controlled trial showing a 26-point drop in blood pressure on average in 3 months. And the norm in standard care is 6 points in a year. So typically we're operating at about 3 to 4 times better outcomes in about a quarter of the time. And because we measure every outcome in real time, and we measure every minute of coach time spent with every patient, we're doing a real-time cost-benefit analysis that allows you to understand the triple aim, because we're also measuring patient experience. So now an organization that used to be in the dark about how its cost correlated with its outcomes now can see all those dials, turn them in real time, because all of this interaction is happening predominantly with patients between visits and all measured so that they can really optimize the care.
So do the patients, when they're experiencing some difficulty, call into this service, or have they been assigned? Has the hospital or their primary care provider assigned them a coach?
Yeah, they have a coach that's assigned to them and that they have a deep-seated relationship with. And that relationship is built around really specific plans and goals that they've set together. And the app on the patient side supports them in that on a daily basis. And when they have questions of their coach, they can fire them through the app with the context of that plan. So it's not just communication that's lacking context. It's conversation around a very specific set of actions and plans and goals that they've set together.
It's very interesting. I think we make a mistake when we label people like yourselves as entrepreneurs only, as if the money or business acumen were the motivation. So, what gets you out of bed in the morning or working late into the night? Did you expect that your medical career would look like this, Dr. Moore?
Yeah, so definitely not. I went into medicine envisioning that I would be practicing, and I quit medicine 8 years ago, really because I was embarrassed at my lack of ability to communicate with my patients outside of the office. I felt that it was inappropriate that it had to be my schedule, my location, my agenda, when really we live in the day of chronic disease, where most of that cannot be addressed in my office. It needs to be addressed in real time as the patient encounters the challenges in the chronic disease management. So originally I thought that I would be practicing medicine and going through the traditional route, but now what gets me excited is every story from a coach or from a patient where they say that this has transformed the way they look at medical care. No longer is it, to them it was a bit in the dark ages, right? Because they can order a package online and they know when it's going to arrive at their door, yet they could show up at a doctor's office and have no idea when they're going to be seen, have no idea how much time it's going to be spent with them. And they leave the office and they have no idea anything that was told to them, right? Because it's so stressful and overwhelming, and the average human has so many questions to be asked during that time, and there's so much stress that we can't really absorb what happens there. So suddenly now they're in a new relationship where someone is there for them any time of the day when they have those issues, right when it happens, so they don't have to squeeze it all into 10 minutes. And suddenly they say, wow, isn't this the way healthcare always should have been?
Well, I happened to look on your website and I saw the story of the, I guess it was a grandfather fixing his granddaughter's bike. I thought it was very affecting. It was very down to earth though. So he had a problem, and he had a couple of problems, and his coach promised to get in touch with his primary care clinicians, and the little girl's bike was fixed after all.
Yeah. Yeah, in the end, if you ask people today, would you like to get your diabetes under control or your hypertension under control, they'll say, yeah, it's probably important. But if you say to them, how would you like a new healthcare experience where when you have troubles, I'm there for you, and where I can help you through the problems. And by the way, we can get some of those diseases that you're worried about under control. And they say, well, that sounds intriguing, right? That's because humans don't care about the distant future. We're not wired for that. They care about more immediate convenience, and they care about social connection. Oh. And that's what I went into medicine to do, really form a bond with patients, to help them through their problems, and to help them be more well. But that emotional, that relationship part is really important. And today in medicine, it's hard to get that, right? Because it's being squeezed out of us. But in this alternate reality that's happening in medicine, where you don't have to deliver it all in the office, it's possible again. You can really form that relationship, communicate, be there for them, and it's really gratifying.
But Dr. Yu, your expectations of the medical career, what changed your focus? I know you're still a practicing clinician at Atrius, but what gave you the idea to start sending data in real time? Was there a personal experience that you had that?
One of the driving passions of my life has been whenever I see that there's an answer out there that we just don't apply, or that a solution that we don't use. So I remember when I was in college, I was an economics major, and I was an economics major because in high school I had some small businesses, and I thought they were so fun. And I was a person who, ever since I was a kid, I wanted to be a doctor, but writing a small business was so fun that I thought maybe I should study economics and at least learn some of the business aspects to understand maybe I would run a practice one day. That's obviously still in the old school of thinking for doctor models. Back then, I remembered thinking that we had huge economic models that wealth begets health and health begets wealth. But I thought to myself, there's no way that you go to any country who is poor and just tell them, you'll get wealthier if your patients are just healthier. So that's the fix. And you certainly couldn't go to flip that and do the same thing and say, well, I'll give you more money and now you'll just actually be healthier, right? Those are macro effects, and they don't at all reflect what is needed on the ground level. And so everything that I think I've done since then has been really motivated by how do we deliver solutions to people who really need it. We understand how to manage diabetes. We understand how to manage hypertension, but we don't do it well. Half of all patients don't have their blood pressure under control, and it's not because patients don't want to or unwilling, and it's really not because I think providers are unwilling. I think there's a fundamental disconnect of how we're doing this. And so I was a primary care resident. I had nothing to do with emergency management. But I realized that as an internist, I was admitting patients into the hospital from nursing homes. And because they had been sick, they were confused. They could not at all tell me what was happening to them for the last few days. Their families were not there, so they couldn't. They were confused. And I couldn't find a story about what was happening. And supposedly there was a run sheet. Somebody had written it down somewhere, but by the time that I had admitted them, those were always never around. There were times where even an EKG was taken at a nursing home that would just be lost because it was a piece of paper that scrumbled up, and no one had a digital version. So I thought to myself that if Twitter can breaking news across the globe by people sending and sharing photos, videos, and very short clips of information, why can't we kind of crowdsource this information? Because everybody is sharing information every step of the way. The gaps in our communication from the ambulance to the hospital is created because there are silos, because ambulances have traditionally been other companies and hospitals work in a different system as well. And oftentimes the emergency department doesn't even talk to the rest of the hospital. They use their own ED trackers, own ED documentation systems. And so this environment has caused so much fragmentation of the data, but yet everybody tries to do their very best for these patients because they know they're very, very sick. That's how we came up with the idea of triage, which is allowing a very simple platform for ambulances to take information in an asynchronous manner whenever they can and pass that forward to later on teams so that everybody knew the first-hand story. Nobody has to play a telephone game of what happened to the patient. We can all understand and prepare for the patient at the right time. And hearing what that's done for patients in Boston, where triage is touching patients. Currently, triage touches about 100 new patients every week, and all of them come in to the emergency department by an ambulance. They're fairly sick. And just in the first 2 weeks of launch with South Shore Hospital here in town, there were 2 critical cases where having the right data really made a real difference to a patient's life. One was that we had a very experienced paramedic who had a hunch that a patient was having an aortic dissection, a critical emergency. But normally there was no easy way for that medic to transmit all that information and activate pretty much an emergency protocol. In fact, the hospital, having heard the information from triage, they gathered a bunch of doctors, talked to the radiologist, and they on the spot invented a aortic dissection protocol to clear the CT scanner, moved everything forward, and because they had all the data in hand. And they didn't have to wait for that patient to arrive. And there was another patient who had fallen from a ladder and was so confused, he actually refused transport when the medics came to him. And actually, they felt this was a tough legal situation where you have a patient refusing, and yet he seemed very sick. They actually took photos of his injuries and sent it over to a physician, and the physician authorized that the patient needed to be brought in because of medical necessity. And when the patient ultimately was brought in, he had injured himself so much, he needed a massive transfusion protocol and a splenectomy. And it was a life-saving event that we were able to make the right decision and empower people on the scene to do that. So those were the challenges, and hearing that has been really eye-opening for people who use triage and for my entire team who built this to help save some lives.
Those are powerful stories, and I guess the system lives on numbers, but I think that the clinicians, you clinicians, live on stories about cases and about the good that you've done. That's very interesting. One of the other experts who couldn't be on this discussion, I believe he may be attending a conference in San Francisco, described his aim this way, and I'll quote, "to disrupt the status quo of the healthcare industry and improve the way patients gain access to the care they need." Do you see yourselves as disruptors? I'll start with you, Dr. Moore, and I mean that disruption in response to the obvious failures of the current system, not as a kind of a throwing things through plate glass windows.
Yeah, we predominantly work with disruptors. Since we don't provide clinicians ourselves, we can't be the actual disruptor. but we seek out those that are building new models of primary care, new models of specialty care that are squarely focused on better outcomes at lower cost and are changing their business models, changing their workflows, changing their staffing, changing the way they work with patients. And we want to facilitate those disruptors in proving to the world just how strong their outcomes are and spreading that innovation.
Huh.
We're an empowerer of disruptors, I would say.
And Dr. Yu, do you see yourself as a disruptor or a facilitator, or how would you describe yourself?
I think that we all have to be. I think we need to have a little bit of change and revolution ever so often, right? You know, in speaking with my other hat, I actually am the Chief Innovation Engineer at Atrius Health, and every day my job at Atrius is think about how to disrupt ourselves internally. You know, we don't want to ever be in a position where we feel disrupted from the outside. We need to keep ourselves young and fresh and agile. We think about ways of delivering much better patient experience, how to delight our patients with every time that they interact with our healthcare system and our people. And so we've actually cultivated disruptors from within, and I think one of the strongest parts of working for Atrius has been the fact that it promotes leaders who actually think outside the box and promotes the ideas of people who can try to bring in outside disruption. So one of the roles of the Innovation Center is evaluating outside technologies, outside vendors, and seeing how that could help Atrius meet the next generation of technology. And certainly for triage, radios have been the standard of communication for the last 100 years. We know it's there for fire, for police, for EMS. It is a major disruption for the market, but with how ubiquitous smartphones and mobile technology has been, if you just look at an ambulance truck and how high-tech it looks inside, I think it is ripe for disruption that the communication finally between that high-tech ambulance truck and that high-tech ED will be something higher tech than a radio.
So as a disruptor, entrepreneur, and clinician, there are people who want to follow in your footsteps. People for whom the prospect of innovation and disruption must be very exciting. So if you could give those people one bit of advice, what would it be?
I think the most important thing for anyone is to figure out what lights the fire, what lights their fire. Yeah. After you find what you find you have the greatest passion for, the rest actually becomes incredibly easy. You will have the energy to meet people, to build products, to go out there and knock on people's doors for money, for opportunities, for a chance, just to show that your idea has worth. So don't be distracted by what other people might be doing necessarily. Find what lights the fire in your belly and understand, this gets me up day after day. One of the challenges of being an innovator is the many barriers in a way. I mean, there's a reason why we do things the way we do right today, and that means that many people will not be an early adopter. They will say no to your face. You can give beautiful examples of a business model. You can tell wonderful, moving stories, but some people still believe that the current process is the way to go. And you have to be ready for that. And in 100 tries, if one person says yes, you grab onto that and you keep on knocking. So find the passion, find the fire in your belly, and the rest will happen.
What about you, Dr. Moore? What would your advice be to somebody who wants to follow?
I wouldn't say much different. I mean, that's the absolute truth in healthcare. Is you need to absolutely believe in what you're doing. It's not a field of innovation to get into for business desires. I think we see a little bit too much of that lately. Healthcare, you need to do it because it's in your blood, because it's one of the most challenging areas to innovate. Despite performance being significantly below other sectors in our economy, it is one of the hardest areas to move forward with innovations that affect the triple aim. So you have to do it because you really believe in it and because you want to make a difference. And it's as simple as that. I have to agree with her completely.
I haven't given you the opportunity to ask each other questions about your experiences. Is there a question you'd like to ask Dr. Yu, or Dr. Yu, would you like an answer from Dr. Moore on a particular thing?
Well, I think one where I would really appreciate John's opinion would be, I'm sure he talks to many hospitals, and there's some hospitals or some health systems that turn him away. That just say it's not the right time, or it's not or we have something else. How do you go back to them and say, this twine is the real solution, or how do you use that experience to make twine even stronger?
Well, I would say that our problem is actually the opposite, is that we don't know, well, we used to not know when to say no. That was our bigger problem. I think in healthcare today, although the organizations have real trouble operationalizing change, the people within those systems have a really intense desire to make improvement. So when we find a champion within an organization, they will almost universally say, yes, we need twine. But what we found is that we need to be extremely careful on who we choose at this stage. And I think that's a big piece of advice for anyone starting a company that's focused on improving the triple aim of healthcare, is that if you just blindly go to organizations that say they want to improve the triple aim, you may not be successful as a company. We've formed a very specific ideal customer profile for us. After 2.5 years now in this business, where we can identify organizations that are interested in making improvements in care, but when it comes down to the day-to-day work and how the fee-for-service payment model affects their day-to-day behaviors, are not yet qualified for that. So I kind of have to turn that question on its head a little bit and say, for most companies in this space, the bigger question is, how do you move quickly and look for those customers that are really ready to make a change? Because you're small, you need to move fast, you need to have big impact quickly, and you can't get hung up in very large systems that are still dealing with whether or not they want to change. I think that's the bigger problem for entrepreneurs today. And once we got over that, our business took off extremely quickly, because we'd say no, 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 and find those yeses that were really ready to change their care model and improve their costs and improve their outcomes.
And so, Dr. Moore, what would you like to ask Dr. Yu?
Yeah, I'd love to hear that from the Atrius Health perspective, what her experience has been like on evaluating different opportunities for them to improve their model of care, and where they've had real successes and where they've struggled, just because they're on the other end of the equation. It's kind of nice for her as an entrepreneur because she gets to see both sides. But I'd love to hear that perspective.
Absolutely. So Atrius Health is an organization that has, I would say, the vast majority of our revenue comes from global payments. So when we think about our patients, we think about global risk and taking most of thinking of the bigger picture, not thinking about fee-for-service. And if anything, our business model continues to push in that direction, because we do not believe that fee-for-service will be here for the long run. We definitely want to be in the business of global risk. So when we evaluate technologies, we don't think about, oh, well, is that a reimbursable technology? Can I get billed for this? That matters much less to us. It sure matters a little, but it matters much less. I think what we are thinking about in many ways is that we care about our entire population. And a fee-for-service environment has created a construct where you should only care about your sickest, most high-risk patients. And so we have programs, or their health systems around the country have programs for their heart failure patients who are the highest readmission risk, and COPD programs for their highest admission risk patients. And that's because Medicare has put up penalties. But it's not true that we don't care about lower risk patients, right? The only reason we've segmented patients in that manner is because we're scared that the cost-benefit analysis doesn't work out for lower risk patients. And I think that's not a working formula. What Atrius Health wants to figure out is the ability to be able to take care of our entire population. And what we do when we talk to vendors sometimes is understand, okay, this is your pricing scheme for if we do the standard model of our highest risk patients where you might get the highest bang for the buck. But what if I want to just roll out your wonderful platform to all of my patients? You know, why do you have to have stage 4 heart disease to benefit from coaching? How about I offer that to more and more patients? This could be an opportunity to engage patients earlier. And I think sometimes when I talk to startups or try to think about it, I actually have to push them to think about a different business model, because obviously, you know, the ROI calculation is different when a health organization starts thinking so globally. So we definitely have to think and push the envelope. At the same time, we're a very integrated system. We use, we've been one of the, I think we're the 3rd ever user of Epic. And so in many ways, we're a super user of Epic. We want information to be called with it very well. At the same time, we're limited by how much we are integrated into one system that may not be at the forefront of integration with many other communication platforms. And one of the things that we are currently tackling right now is understanding how much do we want to bridge out and build platforms so that we can be more agile in working with startups that may not have Epic integration out of the box.
Yeah. Well, it's really good to hear your focus on other tiers of the population besides the highest risk. There's ample new evidence now. You know, people talked for years about the 2 to 5% of patients that consume 50% of the cost. But a lot of that insight is going by the wayside now, proving that focusing on at-risk and rising risk populations is really where the cost savings are. Because if you can prevent that one patient from getting to dialysis, that's where the true cost savings come. And by focusing on people who have already had end-stage complications only, obviously, you want to focus on them because they really need the help, and it also helps the healthcare costs. But in preventing people from reaching those end-stage complications, it's really where the biggest improvement in patient life and in outcomes is. So good to hear an organization really thinking ahead like that. It's still a challenge to get people to digest a lot of that new information today.
Well, Dr. Moore and Dr. Yu, you're both disruptors, and I applaud you for that. And I hope that you'll be able to make some converts out on the open forum that, as I said, ends on January 21st. I want to thank you so much for your time today.
Thank you very much for having me.
Thank you so much.